gastric pain for 4 days. She denied any fever, vomiting, and she had normal bowel movement with no prior treatment. The past medical history was significant for a laparoscopic gastric fixation surgery due to gastric torsion at 18 months old. However, there is no medical report was yet until now. Physical examination showed that there is a firm mobile mass in the hypogastric area, and the latex was within normal limits. So the patient was performed an abdominal CT scan. So this is a CT scan. Here you can see that there is an ectopic spleen, which is really enlarged. The spleen is about 15 times 15 centimeters, and the good thing is that it is homogeneously enhanced, which is a good sign that the spleen is viable, and it is a good indication for a splenopexy. We also perform a CT scan for the vascular reconstruction to see that there is a long splenic vessels over here and partially torsion. However, it is still intact, and the fat stranding around the splenic hilum is we find no fat stranding, so it's a good sign that this spleen is viable. So the patient was diagnosed with vulnerable spleen with partial splenic torsion, and the treatment was laparoscopic splenopexy using the Berlin mesh. So here's how we perform the operation. The patient was set in a supine position, and both the surgeons stand on the right of the patient. We use 4 trocars, and when we enter the abdomen, the intra-abdominal space was clean, and there was an enlarged spleen, about 15 centimeters swollen and purple, permeated to the left lower quadrant and covered by the mesentery. The vessels was long, dilated, and it was partial torsion. So we decided to dissect the spleen from the surroundings and detour the splenic vessels to see that the spleen becomes pinkish and becomes smaller. So we decided to conserve it by using 2 sheets of Berlin mesh sewn together at 2 opposite sides. Then we put the spleen inside, and we stabilize the bag with a hemolock and a V-lock sutures. We leave a hole for a splenic hilum, and then we suture on the back to the anterior and the left abdominal wall with Berlin 1 serum. The post-operative period was uneventful, and the patient was discharged on POD 3. The patient was really satisfied with the treatment due to the advantage of the aesthetics, fast recovery with less pain, and the patient may avoid complications from splenectomy, usually relevant to the immunology. So I would like to go through a little bit literature review about the vulnerable spleen. The incidence of vulnerable spleen was reported to be about 0.5%, and it occurs more in female than male. The mean age at diagnosis was about 24 years old. About the backbone physiology, we may see that there are usually 4 ligaments that help to hold the spleen in place: the gastrosplenic, splenorenal, splinosplenic, and splenocholic. And if there is any anomaly that cause the abnormality or absence of the ligaments, then this spleen will fall into another place. So there are also reports that there's a comorbidity between the gastric volvulus and the vulnerable spleen. And here in our case, the patient has the gastric volvulus before. So we may think that the vulnerable spleen at this time may be a misdiagnosis or a newly acquired during the time that the patient grew up and the spleen dropped down due to gravity. But it is helpful to keep in mind that when we explore a case of gastric volvulus, then we should remember to check the spleen and other organs. For the management, we have 3 choices: splenectomy for those at late diagnosis, splenopexy for those cases when the spleen is still viable, and there are also reports of conservative management when the patient doesn't need any surgery. About the imaging diagnosis, we may see that there is a splenomegaly when the spleen is enlarged due to lack of blood going back due to the blood vessels being obstructed.